All right. So my opponent stood up here and he spun you a very tragic tale, referring to Mr. Mitten. And yes, we will agree that that was a horrible situation to be in. The problem, and he stated this when he spoke to Mr. Mitten, is that it's not, that example is not a typical case, and it's not what this legislature would actually be dealing with. In fact, it's actually probably a great example of why euthanasia or physician-assisted suicide should stay illegal or not be legalized across the United States. We're going to demonstrate why it should stay this way by pointing out, or by showing that the desire to kill oneself is a sign of depression and mental instability. The mental toll on doctors who perform these acts is actually much greater than they will want to admit. And given adequate or excellent palliative care for terminal patients can actually end their lives relatively pain-free. Now, before I get into my main points, I like to think that you guys are pretty smart group of people. So we're going to do a quick logic exercise. My opponent's first claim was that Americans deserve the right not to suffer. And that is a great point. However, there's an inherent logical flaw that they don't seem to understand, that suffering in and of itself is a subjective term. Suffering is not the same for me as it is for you, as it is for anyone else who is actually in any type of pain. On a scale of 1 to 10, my 5 might be your 10. If I pinch myself, it doesn't hurt, but for you, that might be excruciating pain. And he's saying that these patients are, making these claims to these doctors. They are terminally ill. However, the doctors are looking at this as, okay, they're in an extreme amount of pain, and he's saying that they have a competent amount of skill to actually judge whether or not this person is truly in an excruciating amount of pain and should be allowed to end their life. He then goes on to say that these patients would rather end their life than be in any type of sedated state or maybe not fully sharp state due to pain medication. And that's another assumption on behalf of the patients that our opponents are making. They don't know whether or not if the patient was given the option between having an adequate amount of pain medication and sacrificing a little bit of mental sharpness would actually be a choice that they would make. It's really impossible to actually make these decisions for them without talking about a case-by-case basis. And that's one of the things that leads me to my first point, is that these patients are not mentally capable of making the decisions for themselves as well, because they are clinically depressed. Dr. Robert L. Fine, director of the Office of Clinical Ethics for the Baylor Healthcare System in Oregon, actually states that as many as 77% of terminally ill patients are clinically depressed. He goes on to say that it is treatable in many cases, and early treatment is more effective than late treatment. Early treatment is, of course, depending on early recognition of the problem, and all too often physicians wait until the last weeks, or as my opponents pointed out, when they're ready to die, they go through a psychiatric evaluation, and by that point, it's generally too late. At that point, the depression is taking over, and it's part of their personality. So it's pretty clear that euthanasia is an idealistic situation, but by the time that a patient is in the situation where he has to make a choice between life-ending care or the decision to take their own life, that they're already past the point of making any decision that is actually in their best interest. Now, in regards to the doctors in my second claim that are actually performing these acts, Kenneth R. Stevens, a professor at the Oregon Health and Science University, vice president of Physicians of Compassionate Care, states that 50% of euthanasias and 40% of assisted suicides were followed by burdensome feelings on behalf of the doctors. 48% of the euthanasia and 49% of assisted suicide cases were followed by emotional discomfort and go as far as seeking emotional support in 43% of euthanasia cases. The American Medical News also quoted Peter Emmerdahl, a leader of Holland's euthanasia movement, saying that you will never get accustomed to killing somebody. We're not trained to kill. With euthanasia, your nightmare comes true. In essence, what you're asking these doctors to be responsible for is ending a life, not a patient refusing treatment, which is known as passive euthanasia, but actively assisting in someone dying. It's the opposite of what they were always trained to do. Now, our third claim is that alternative palliative care can make the last days of a patient relatively pain-free. And Kathleen Foley, professor of the Department of Neurology at the Weill Medical Center of Cornell University, states that, or is opposed to legalization of euthanasia, and states that the strongest among physicians who know about caring for terminally ill patients say that the patients requesting physician's assistance in suicide are usually telling us as strongly as they know how to that they desperately need relief from their suffering, and that without such relief they would rather die. They are making an anguished cry for help and a very ambivalent request to die. When they are treated by physicians who can hear this pain in their voices and understand their desperation, they are able to relieve that suffering if given enough training. So, you know, our opponents do make good points in that Americans should not be required to suffer. But there are alternatives to suffering. There are ways to alleviate this without killing someone. And that's really what we're talking about today. Allowing people to kill other people.